But there is so much of the health service that we still don't know about the quality, and where quality is much more variable. And actually, I would argue that focusing our measures on outcomes on these areas would be much more effective, much more beneficial for our health service. Areas of concern about quality, including unexpected emergency admissions. 40% of the NHS's acute hospital admissions, which have much, for the same operations, laparotomy, for example, major abdominal surgery, and elective have much lower mortality than the emergency equivalent. When you have emergency admission, you usually that space is not unable to be offered to elective care. So there's always a concern about capacity, emergency and elective balance. The management of long-term conditions increasingly important. We don't know how this is, this will be of increasing dialogue importance, and there's much more unknowns about quality. Multi-morbidity, dementia, very important. Primary care, social care, increasingly important, the transformation between health and social care and the integration of these two services. About quality of care homes, there's a lot of questions about that. And also mental health services. These are all really important areas where there is a lot more, at least in England, questions about unknown variation, unknown quality. So I'm going to show you briefly about two examples from our research from our school. The first one is my own, and the second one is my colleagues, about looking at PROMs and using PROMs in these aspects of care that we don't know much about, but there are challenges in how we collect PROMs in these areas. That's why it hasn't been widely done in the past. So unexpected emergency admissions, the challenge. This is my doctoral thesis. We don't have the information on the health status before the event. I already mentioned that PROMs you collect before and after, and you measure the change, and you can see the change in health status. But in emergency admissions, we don't know. We don't have that. So we can use, the question for me in my doctorate study is, what can we do? Can we use, for example, retrospective PROMs? So what's a retrospective PROM? Before the event, this is health status of a whole quality of life, whatever you want to use, and of the patient before in the time and the timeline. So this is the two axes. Before the event, the stylized diagram, patient's happy, plodding along with their normal daily life, and then they have an acute event, and their quality of life drops, and then they are admitted to hospital and they receive treatment, and then they are asked to retrospective PROM to recall how they were before, and then a follow-up PROM afterwards. So retrospective PROM is like a recall PROM. You ask the patient during their inpatient how they were before the event. Because we are interested in capturing a baseline of patients, and we're about helping patients recover. So in my study, I've asked patients to recall how they were within a month. So they're still in hospital, and when they're after the emergency treatments, after they're well, before discharge. How are you before, when a month ago, before you were admitted to hospital with your current episode of illness, and you ask them to recall. And then a few months later, when they were recovering, we send them a follow-up PROM as per normal, how other PROMs, how the elective PROMs are done. So what is the accuracy, reliability of retrospective PROM? And in my study, so I first of all did a systematic review, it's published now, looked at if there has been a prior comparisons between contemporary PROMs and emergency admission PROMs. And the comparisons are limited to elective admissions, of course, because we're asking to look at if patients have done a contemporary PROM and a retrospective PROM together and how much agreement it has. So there are very few, but there are some studies, usually in hip and knee, arthroplasty, some prostate hypertrophy. Some studies, 6 studies, found very strong correlation and also very strong agreement, inter-class correlation coefficient of above 0.75. Okay, so we know that at group level from the literature review that PROMs can reliably predict contemporary PROMs, and the stronger it is for indices and shorter time levels is what the systematic review found, and also stronger for disease-specific than generic PROMs. Then I did my own cohort study in the NHS with patients of hip and knee replacement as well, a much larger study than some studies before. I also looked at people admitted routinely to NHS for hip and knee operation who've completed a PROMS on the normal national PROMS program, and also completed a retrospective PROM just before their discharge, after their operation. And I found in my own study that actually the interclass correlation absolute agreement is 0.82 for disease-specific, and around 0.62 for EQ5D. So strong and very strong intraclass correlation absolute agreement, and the consistency is also good. And this is what my own findings were. So we found that retrospective PROMs can predict contemporary PROMs, and that we can use that as a way of collecting PROMs in emergency admissions. So I then done a feasibility pilot study in 2 emergency admission cohorts. First of all, with emergency laparotomy, 11 hospitals around the country, and with STEMI, ST elevation MI patients, heart attack patients, at 5 PCI centers, so primary angioplasty centers, 2 largest cohorts of patients, and did retrospective PROM and a 3-month follow-up PROM, and looked at the feasibility in terms of acceptability for patients and staff, and interpretability and how we can use it, for example. And you can see here on the right that the different hospitals have varying ability to capture PROMs, and this is normal. This is very similar to elective PROMs. Some hospitals have much higher recruitment, but on average, 85% were eligible of all the admissions that survived were eligible. 84% of those were invited, and 72% participated for emergency laparotomy. This is large emergency abdominal surgery where surgeons have to open up the patient abdomen when they're admitted as an emergency, and have varying diagnoses and pathologies. Quite an important, significant major surgery with about 10% to 15% mortality, 30-day mortality rate. It's improving, the mortality rate. Majority of patients survive, but can we do a PROM? ST elevation MI as a medical condition, patients have very short inpatient stays in this case. They have a significant heart attack, again, varying severity, but all of these are ST elevation, which puts them on a more severe category. They have to have a PCI within 90 minutes of, the guidelines is within 90 minutes in England at a PCI center. And after the PCI, before their discharge, they complete the PROM. Again, there's varying degrees of success in terms of collecting the PROM, but some very, very high, nearly 100% capture rate. So 85% similar percentage of patients were eligible to complete a PROM. There are those that have cognitive impairments, other impairments that prohibit social reasons that they couldn't do the PROM. 79% were invited, and 92% participated on average. So yeah, this is just a little bit more information of this. At 3 months, I then collected their follow-up and as a feasibility study to look at response rate. So actually, there was 72% responded, and for emergency laparotomy as an example. And for the first time, we were actually able to look at how patients, so before I did the feasibility study, I had a look at clinical guidelines, anything about the recovery trajectory of the patients in emergency laparotomy, and I couldn't find anything on the internet. Actually, for the first time, we are able to quantify how patients' symptoms and health status recover after an emergency laparotomy episode. And we can see that actually for their Jiggly index, so the overall score, patients actually recovered to baseline and improved. So the baseline was 93.3, and then their follow-up 3 months was 97.9. So not only does it suggest that they were before the acute event, there was some underlying pathology, and after 3 months after the operation, not only have they recovered, they actually improve. And then similarly with their symptoms. Their emotion and physical scores, the subscales, have recovered essentially, and the social score had decreased a bit. I mean, they have just undergone a major surgery. So actually these are quite helpful, and it's for the first time that we've done that. And for the EQ5D, we've also seen an improvement actually after 3 months after emergency laparotomy emissions, an average. So this is something what we can do that we've not ever done before, and we had 74% response rate, which is good. As good as the elective hip and knee actually. On average. So I'm going to talk very briefly about my colleagues' work in LSHTM as well. Another aspect of questions about quality of care is actually mental health and long-term conditions, and dementia care is an interesting one to study. People with dementia may have limited ability to respond to a PROM. So how can we capture a PROM for those with cognitive decline? Increasingly important question. As you know, my study, there were some patients that were not eligible. And for those, some were social reasons, like they didn't have an address and they didn't live in England, for example, but others were that they had cognitive impairment that was not reversible, so they couldn't complete their own PROM. So in that case, what do we do? And so actually my colleagues looked at patients and caregiver proxy PROM. So how can we do that basically? So they used the DEMQOL, which was developed by my colleagues in a London school. This is all published, so you can. I'm happy to provide you with references. So the DEMQOL-Proxy, which is a caregiver, so informal caregiver, so their spouse or like next of kin, to report the patient's quality of life, some information about this, the domains that they cover. So really, the question here is, can proxy scores predict patient scores? And they captured patients with different levels of cognitive impairment, patient with dementia, they self-report. This is the quality of life, and this is how the cognitive impairment. And we know that patients can report to a certain extent, but their quality of life goes worse when their cognitive impairment is worse. So this is the trend of the patient score, and this is the trend of the proxy report. So we know that caregivers consistently score below what the patient self-report is. But when the patient no longer self-report because the dementia is so advanced, the caregiver can continue to report. And then they have done psychometric analysis to show that actually you can map across the two. So you can actually map across patients to caregivers. So when the patient can no longer report, you can use the caregiver's report. So they have looked at how you can do this. So just to conclude, some final thoughts. PROMs can help disrupt traditional PROMs. So hopefully, today we've covered the traditional ways we measure health and how that hasn't really progressed. The current complexities of our health service and the increasing need to focus and the desire to focus it back to the importance of our outcomes and our patients. And so hopefully PROMs have shown you that PROMs can disrupt as a disruptive technology, provide traditional approaches of clinical care, and that they can do this in an individual patient's level with the clinician-patient interaction, which we covered throughout the course, but also to policies, the importance in the policy climate. There are definitely lots of still methodological and practical challenges to how we can capture them and also facilitate the wider use, and also how do we improve healthcare services with them. But there is definitely potential and support in us helping to really look for the question on how do we define, assess, and measure quality, and how do we help support the integration of health and social care and all the many health challenges that our current health services face. So hopefully this is an introduction and overview to patient-reported outcomes. Thank you very much.